See, actually what I was talking about the technology is that in the Zeeman machine, when the femtolaser is passing, you are not seeing it. So that is why you could end up with a decentered. I think the new one allows you visualization, right?
No, that's not the reason. What happens in Zimmer is when you are docking the eye, it takes an image and puts it on the screen.
Okay.
So once you've taken the image and you put it on the screen, and then the eye moves below.
Okay.
When the section is being built up, you'll have a decentered flap. So this they didn't tell you when they sold the machine to you, but I realized with the first decentered flap, and now I know exactly what to do, and now I don't have any such issues. But that's how the technology is. So bottom line is, whatever femto you buy, you must know it in and out, and then you have no issues.
Thank you. Any questions for Kumar? Okay. I'll go on to the last topic of this instruction course. That's basically the merging of cataract surgery and refractive surgery. And that's what today's cataract surgery, the patient is expecting, if not elimination of glasses, at least a reduced dependence on glasses. And what's happening is that more and more younger patients are developing cataracts, and they are the cataracts are being operated much earlier than they used to be, say, when we were residents. And we in cataract have the one of the highest rates of post-operative satisfaction, but the patient is looking at spectacle independence. Now, if you look at a cataract surgery being done today / a LASIK surgery, I am bringing out this comparison. The complications in cataract surgery in the best of the hands of a surgeon are 10 times the complications that you get in a LASIK procedure. The LASIK procedure has evolved into being something far safer and at a higher level than a cataract surgery, and that is because of several reasons. You can't refuse a cataract surgery to a patient saying that you are not a fit candidate. Even if you have a subluxation, you have a hard grade 5 cataract, you have to do a cataract because that's a necessity. And the tight screening that we do in a case of LASIK takes away a large chunk of complications. But in a cataract surgery, if you look at it, these are the complications that are there. And one of the important complications is how to target emetropia. So the cataract procedures are today tending towards refractive cataract IOL technologies, and there is a need for surgeons to expand their refracting offerings to the growing patient demand who are looking at getting an emetropia. This is just a schematic diagram or a presentation of
It is called a femtosecond laser because it controls the A femtosecond is equal to 10 second, or 1 millionth of 1 millionth of a second. A femtosecond laser works by focusing light no wider than 3 microns into the tissue. The laser energy disrupts chemical bonds and generates plasma within the tissue. The plasma gas quickly expands and displaces the surrounding tissue. As the plasma dissipates, it leaves the cavitation bubble. A femtosecond laser incision is produced by performing thousands of laser pulses every second. This produces continuous, tightly controlled tissue separation. By adjusting the depth, size, and location of each pulse as it fires, X laser can create cuts on multiple types of tissue.
Okay, that essentially was how a femtosecond works, because we've been talking about femtosecond. Now, when we look at the refractive outcomes of a cataract surgery, 45% of the surgeries are within half a diopter of the intended refraction. 72% are within a diopter and 94% are within 2 diopters. Important considerations are the IOL power calculation and the effective lens position. That means that post-operatively, where is the intraocular lens sitting, and that is going to be directly determined by the size, shape and positioning of the capsulorhexis. So getting a capsulorhexis which is bang on where you want it is going to be a key determinant on the effective lens position. If you have a larger axis, this will give you a shorter effective lens positioning, and if you have a small capsular axis, it will give you a longer ERP. Now the effective lens position, if you can see here, if it moves back or if it moves forward, depending upon how good or bad your capsular axis was, a 21 diopter lens can produce either a refractive status of a 20 or a 22 diopter. So that is what is the difference if there is a change in the effective lens position. And further, a capsular axis is also important in inducing a tilt in the final position of the intraocular lens. And you can see very clearly these are lens-induced aberrations. If you have a tilt, and this is the comparison, you can see a comparison of the wavefront where there is a tilt slash where there isn't a tilt. So the quality of vision and the way you are going to achieve emetropia are going to be determined by several factors in cataract surgery. So when you are looking at premium intraocular lens technology, you need an optimum size, shape and location of the capsular axis. You need also to treat coexisting astigmatism, and you need to reduce the quantum of phacopower that you are using for doing this particular procedure, and this is achieved by the femtocataract. And this is, as you can see, the capsular axis which you get out of a femtosecond cataract repeated. It will not be different between if A person does it, B person does it, C person does it. You will get the same capsular axis bang on bang, and this is just to show you a post-operative picture. Second issue, corneal incisions. You all know that the corneal incisions induce astigmatism. And if you are to calculate your surgically induced astigmatism, you need to be repetitive in the type of incision, the shape, the size and the location of the incision. And you get this in the femtosecond laser. And if you see the normal analysis of a population, the average astigmatism preoperatively is about 0.9 diopters. So there would be more than 4 out of 10 cases who would require some form of astigmatic correction or going for a toric intraocular lens. What I do today with the femtolaser is that if there is a coexisting astigmatism that is between 0.75 to 1.5 diopters, I do arcuate incisions which could be single arcuate or which could be single or double arcuate. But if the astigmatism is more than a diopter and a half, I go in for a toric intraocular lens. Now, let us see what exactly, how this procedure is taking place, and I'll run you a video as to, this is a live surgery demonstration. There is this is the outside view. This is the docking that you can see that has happened. This is the incisions that have been planned. This is the primary incision. This is the LRI. This is the capsulotomy. If you can see, this is the capsulotomy. We have also made 2 markers here for the toric IOL or the cyclotorsion if you want. And once you have this docking, you can center the capsular axis, as you can see, and this is a 4-quadrant crack that we are going to do in this particular case. And we will go on to the next situation, where is reducing the size of capsular axis slightly. Now, as we keep looking on this further, you will get an OCT image. This is an OCT image that is thrown up. This is the anterior capsule of the OCT which is there. And there are 2 points which have to correspond to the highest and the lowest point in the capsular axis. Can you see this? So we have matched this, and you will get a contour curved capsular axis which is going to give you a circular capsular axis. This bar has to be on the green, and you can see we have brought this on the lowest point. This is the highest point. This is actually real time. There is no editing. Now this is the lens. This is yellow part is showing you on the OCT. We can go down. Still on the default, this is the area where we are going to get a nuclear fracture. You press accept, then you go on to corneal thickness. Now when you go on to corneal thickness, this is, you can see the corneal incision. Can you see this? So you make a triplanar incision as you want, and then you press accept. After you have pressed accept, you will go on to the LRI or the arcuate incision that has been made here, and this is, we set it at about 90% of the corneal thickness in the periphery where we are going to do the LRI. So we press on this area, see that it is fine, and we are ready to fire. Now once you are firing, the first step that appears is the round capsulorhexis. Can you see this? This is the capsulorhexis. The next is the 4th quadrant. You can do 4th quadrant, 6th quadrant, 8th quadrant. You can do a grid pattern. There is absolutely no problem. This is showing the laser as it is firing. It fires from down up. As it comes, then you see this is the LRI incision, and this is the primary incision that is being done. And once the primary incision is done, you have, after the completion of the primary incision, this is the secondary incision. The total time that the laser fires is less than 40 seconds. And the total time, as you can see, for doing the tire placements is not more than 2 to 3 minutes. This is, you can see now, we have opened the LRI. Can you see this? This is a free-floating capsulotomy. You can see that there is hardly any adhesion, and we are able to remove the capsulotomy pretty well. Once you have removed the capsulotomy, as you can see here, that's the capsulotomy that is being pulled out. You go about, do the hydrodissection, and you can remove these quadrants. I'll go on to the next video because there is paucity of some time. I'll show you this particular case. This is femto laser assisted cataract surgery, grade 5 cataract. You will see that it's actually a black cataract when you have these things pulled out. People say it doesn't work in hard cataract. This is the hardest cataract that I've done, but I've done several more. You can see that the capsulorhexis has been done already, and you can see these are the quadrants that have been created. I'll just move forward. Okay, that's the capsulorhexis that is being removed. Okay, there the capsulorhexis comes out. Round circular capsulorhexis. Now look at these grooves. Can you see these grooves have gone pretty deep? We've done the hydrodissection. Now watch. Just watch it. There, you see that's air bubbles that have come, so that means there is a cleavage plane. Can you see that cleavage plane? Fantastic cleavage plane. Look at this cataract. Black, dark brown, black cataract. And you can see that clear cleavage plane. See here. That's the cleavage plane that's already been created by the lens X. And that is the final piece that has been removed. So if I look at this patient post-operatively, day 1, this is how the patient looked day 1 post-operatively. In a black cataract patient, day 1, because the effective energy that you used because of the femto procedure got substantially reduced, and this is the hardest cataract that I have cut, and it cuts almost all grades of cataracts. There is no problem. Now let's look at again the advantage that you have. Some of you might have seen this. This is a phacomorphic glaucoma patient. We just fast forwarding it. Patient came with a pressure of 60. We gave mannitol. You can see this is the anterior capsule that is there. Look at this. Can you see this? This is the angle which is compromised, and you can see this is again this is the LRI that we are doing. Now watch this particular case after we do, because it is a closed chamber technique. Look at this. This is a swollen lens, angle closure. Huge lens, intumescent. Look at that pulse. Look at that capsulotomy. Look at that fluid that came out. But this is the LRI. But because it's a closed chamber technique, you do not get the typical Argentinian flag sign which you would have got if you were making a small nick in this particular case. I'll just show you the capsulotomy coming out. Can you see this? That's the. I've gone forward. That's a round capsulotomy that we were able to take out in this particular case. One more, this is day 1 post-op, fibrotic capsule. Post-traumatic fibrotic capsule that you have, we have already done the lens sex. I will show you how the capsulotomy looks in this particular case. Only one area of adhesion that was there, we just injecting trypan blue. You can see that, removing the air bubble, and look at that. That's the capsulotomy. You can see there was this huge amount of fibrosis. Can you see this? This is a fibrotic capsule. There is only one little area of adhesion that has been left in this fibrotic capsule, and there you can see we get a beautiful round capsulorhexis, despite it being a post-traumatic fibrotic cataract. And a capsule, if we were to do a capsulotomy normally using a Vanas in this particular case, it would have not been a perfect round capsulorhexis. So, friends, you can see in these particular cases, this is the end. You can see the round capsulorhexis, perfect. Despite being a very difficult case, there you can see this is all fibrotic. This is all fibrosis of the capsule which was there pre-operatively in this particular case. So you can do it in small pupils. You can do also removal of silicone oil. The LRIs that we do in these patients, which give you a fantastic refractive result. The nomograms are pretty standard, and you can work on these nomograms because it is real time in vivo OCT that you are getting. You are able to work at precisely the thickness or the depth that you want the cut to be, and you get excellent results. And to top it all, the icing on the cake would be that soon we will have the flap that will be available with the LensX system. So you could have an OCT guided flap for the femto LASIK that can be created within this single machine. It is the same machine, the heart of the machine is the same, only the numerical apertures change so that you focus on different layers on the cornea. And friends, femtosecond cataract surgery or a cataract refractive surgery is becoming rapidly the gold standard for premium IOL surgeries in the Western countries. There are more than 550 installations of the femto in the world, and there are more than 3 lakh procedures of femto cataract that have been done. So in India, I think there are more than 22 installations that are there. In Delhi alone, I think there are 6 installations now of the femto cataract. So this is, I would say, a technology that gives you an ideal capsulorhexis size, shape and location, creates self-sealing clear corneal incisions with optimum architecture, can treat coexisting astigmatism, reduces dramatically, as I showed you in a grade 5 cataract, the amount of photoenergy and the time that you need for doing these procedures. So the difference, friends, I would say is obvious, and this is the way how technology is going to take us. So be prepared for making all your cataract surgeries also a refractive surgery with the end of achieving the target emetropia in all your patients. So I feel that the sooner you adapt to this technology, the better it will be. Though I am sure the prices of technology are crashing and they would reduce further, and maybe it might become economically more viable at that particular time to buy the technology. But if I have to put my money today on some technology which is going to be the future, it is the femtosecond cataract technology. Thank you very much for your kind attention. Thank you.